This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2010, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on BiLevel ventilation theory and application. This program is sponsored by an unrestricted educational grant from Draeger. Reagan Hickey will take a few minutes to familiarize you with our sponsor. Reagan?
Thank you, Bill. Draeger has added several new ventilators. Its newest critical care ventilator is the Avita Infinity V500. This ventilator provides tools for the respiratory therapist, including variable pressure support, APRV with auto release, configurable Smart Care PS, Smart Pulmonary View, on-screen tutorial operator manual, and exportable data via USB. Another addition to its ventilator line is the BiLevel VN500. This neonatal-specific ventilator provides volume guarantee and mandatory minute ventilation, leakage compensation, apnea auto-return, and 7-day trending and customizable data displays. Finally, the Carina, a flexible and compact NIV ventilator, is available from Draeger. It offers Sync Plus technology and adapts to varying leakages. It is small and portable and designed to fit the patient comfortably. Draeger hopes you will enjoy today's presentation. Back to you, Bill.
Thank you, Reagan. Upon completion of this AARC webcast, participants will be able to distinguish between airway pressure release ventilation, APRV, and BiLevel positive airway pressure, BiPAP modes. Identify the benefits of unrestricted spontaneous breathing during pressure-controlled modes. Describe how pressure settings and time settings affect auto-PEEP mean airway pressure and tidal volume during APRV, and describe how you would manage APRV in cases of poor oxygenation or poor ventilation. I am pleased to introduce Mr. Robert Chatburn. Rob is a registered respiratory therapist and an AARC fellow. He is the clinical research manager in the section of respiratory therapy at the Respiratory Institute of the Cleveland Clinic. He is also associate professor of medicine at the Lerner College of Medicine in Case Western Reserve University in Cleveland, Ohio. Rob has published extensively in the peer-reviewed literature and is one of the top research respiratory therapists in our profession. If you search his name in PubMed, you will find no less than 64 articles for which he is listed as an author. Mr. Chatburn discloses that he has received compensation for consulting work from the AARC, Draeger, Hamilton, CareFusion, Covidien, Newport, Ingmore, Radiometer America. He has also received grants from Breathe Technologies and the Alpha One Antitrypsin Foundation. Rob, welcome to the program.
Well, thank you, Bill. And we have an awful lot of information to present in the next 45 minutes, so let's jump right in. Before we can enter a dialogue about BiLevel ventilation, we must first agree upon some basic definitions. I'm going to be using the term BiLevel ventilation in a general way to mean pressure control intermittent mandatory ventilation, or IMV, with unrestricted spontaneous breathing. Specifically for this talk, BiLevel includes APRV and BiPAP. In addition, we need to agree on some basic terms of mechanical ventilation. The most basic terms are spontaneous and mandatory breaths. We use these terms all the time, but seldom give them explicit definitions. However, when describing modes of ventilation, we need to be more specific. Therefore, we will define a spontaneous breath as one for which the patient has control over the timing. More specifically, this means the patient controls the inspiratory time and expiratory time, or equivalently, the frequency and IE ratio. Note that this definition does not imply connection to a ventilator. In contrast to a spontaneous breath, a mandatory breath does imply connection to a mechanical ventilator. A mandatory breath is one for which the patient has no control over inspiratory time or expiratory time, or both. Also, the terms trigger and cycle are defined here as the acts of starting and stopping inspiration, respectively. Therefore, a spontaneous breath can be defined as one for which the patient both triggers and cycles inspiration. And therefore, a mandatory breath is anything else, namely a breath for which the machine triggers and/or cycles inspiration. An assisted breath is one for which the ventilator provides some portion of the mechanical work of breathing. We can determine that this is occurring by noting that the transrespiratory system pressure rises during inspiratory flow. Transrespiratory system pressure is the pressure at the airway opening relative to the body's surface, or equivalently, the airway pressure displayed on the ventilator. Volume control is a mode of ventilation for which the inspiratory volume waveform is preset, and airway pressure depends on respiratory system mechanics, including resistance, compliance, and patient effort. Patient effort is often described in terms of ventilatory muscle pressure, or PMUS. Pressure control is a mode of ventilation for which inspiratory pressure waveform is preset, and the inspired volume depends on respiratory system mechanics, again including resistance, compliance, and patient effort. Mechanical ventilators assume a very simple model of the respiratory system, composed of only a single elastic compartment representing the lungs and chest wall, and a single flow resistive component representing the airways, natural and artificial. The lungs and the chest wall are described by elastance, and the airways are described by resistance. Respiratory system resistance is defined as the ratio of pressure change to flow change. The pressure is measured across the airways, that is, from the airway opening to the lungs. A high resistance means that a relatively high pressure is required to deliver a given flow. Respiratory system elastance is defined as the ratio of pressure change to volume change. Here, pressure is measured across the lungs and the chest wall. High elastance means that a relatively high pressure is required to deliver a given volume. Sometimes we find it more convenient to talk about compliance, which is defined as the ratio of volume change to pressure change. Low compliance means that a relatively high pressure is required to deliver a given volume. The concept of mean airway pressure is based on the mean value theorem from calculus. This theorem has a graphical interpretation. The mean value of a repeating function is the area under the function divided by the time for a cycle. In the graphic, we see that the area under the pressure curve for one ventilatory cycle is represented by 42 small boxes on the left at the top. In the graphic on the right at the top, we see the same area, that is 42 boxes, is flattened out so that the area occurs only under a constant pressure equal to the mean airway pressure. This is graphically equivalent to dividing the area by the total cycle time. In the case of mechanical ventilation using pressure control, and specifically BiLevel modes, mean airway pressure is determined by the difference between P high and P low and the duty cycle, expressed as a fraction rather than a percent. And in this case, duty cycle is the percent inspiration. We'll talk about that more in a second. Respiratory system mechanics determine the speed of filling and emptying of the passive respiratory system. This concept is particularly important when we talk about BiLevel modes. A convenient index of the speed of emptying or filling is the time constant. A time constant is the time necessary for the passive respiratory system to empty or fill by 63% in response to the pressure rises or releases during mechanical ventilation. Mathematically, the time constant is calculated as the product of resistance and compliance and has the units of time, usually in seconds. The concept of a time constant is very important for understanding BiLevel modes like APRV and BiPAP. On the left, we see the characteristic pressure, volume, and flow curves associated with pressure control ventilation. As the airway pressure makes abrupt or step changes in the inspiratory or expiratory direction, volume and flow respond as an exponential rise or fall. The time that it takes the volume or flow to rise about 63% is the time constant. On the right, we see a graph of the volume and pressure plotted against time constants. We see that after an inspiratory time equal to 3 time constants, about 95% of the tidal volume has been delivered. Conversely, after 3 time constants, the same amount of volume will be exhaled. An important concept here is that the amount of auto-PEEP in the lungs can theoretically be predicted based on the patient's respiratory system time constant and the expiratory time set on the ventilator. And we'll see that this is going to be quite important concept when we talk about APRV. Now, there are 2 main conventions used to express inspiratory time relative to the overall breathing pattern. Perhaps the most common way is the IDE ratio. The IDE ratio is defined as the ratio of inspiratory time to expiratory time. The IDE ratio for normal breathing is often assumed to be 1 to 2. The IDE ratio can be calculated if you know the ventilatory frequency and either the inspiratory time or the expiratory time. You can avoid confusion when comparing IDE ratios by remembering that the ratio actually represents a single number. For example, a ratio of 1 to 2 is larger than a ratio of 1 to 3 because 1 to 2 equals 0.5, whereas 1 to 3 equals 0.33. Ratios larger than 1 to 1 are referred to as inverse IDE ratios. Another convenient way to assess inspiratory time relative to the breathing pattern is the duty cycle. The duty cycle is defined as the inspiratory time expressed as a percentage of the ventilatory period. The period for a repeating waveform is the inverse of the frequency. Because the ventilator frequencies are usually expressed as breaths per minute, the duty cycle is usually calculated as 60 seconds divided by the frequency to maintain dimensional integrity. You can convert an IDE ratio to a duty cycle if you need to, using the equation shown on this slide. This slide illustrates the 2 basic approaches to ventilator control. If the ventilator controls flow, it controls volume indirectly by definition and vice versa. Usually, inspiratory flow is held constant during inspiration, causing volume and pressure to rise linearly. Inspiration ends or cycles off when a preset tidal volume is met. And in contrast, with pressure control ventilation, airway pressure is usually held constant during inspiration. This causes inspiratory flow to decay exponentially from its peak value towards 0 as volume rises exponentially. Inspiration usually ends after a preset inspiratory time, or in the case of pressure support, after a preset inspiratory flow threshold has been crossed. Notice that pressure control modes have an inherent advantage over volume control as far as oxygenation is concerned. For the same tidal volume, pressure control results in earlier lung opening and a higher mean airway pressure, and thus a larger mean lung volume than volume control. Within reasonable limits, oxygenation is proportional to mean airway pressure. BiLevel modes actually got their start in neonatal ventilation. Neonatal ventilators were originally very simple machines that were essentially a continuous flow source connected to 2 pressure pop-off valves, allowing the infant to breathe freely during any portion of the ventilatory cycle. When pressure control modes for adults became available, they sometimes did not allow the patient to breathe freely during mandatory breaths like neonatal ventilators did. Only later did this feature become available, and has since been referred to as being due to the so-called active exhalation valve. Airway pressure release ventilation and biphasic positive airway pressure modes were introduced in the late 1980s. These modes differ from conventional pressure control modes in that the operator interface essentially emphasizes setting inspiratory and expiratory times rather than frequency and IDE ratio. Now, a curious fact is that some forms of pressure-controlled IMV still permit active breathing and some do not. Even more curious is the fact that you can find both of these on the same ventilator. Let's take a closer look at the differences between pressure control with and without an active exhalation valve. On the left, we see waveforms recorded using the AVIA ventilator in its pressure SIMV mode. In this mode, the active exhalation valve feature is not used, so the patient inhales. If the patient inhales spontaneously during a mandatory breath, they are prevented from exhaling. During the attempted exhalation, exhaled gas is compressed into the expiratory limb of the patient circuit rather than being vented to the atmosphere. As a result, airway pressure rises above the set value. And then when the mandatory breath is time cycled, a larger volume is exhaled because it is the sum of the mandatory and spontaneous breaths essentially stacked together. Now, in contrast, the AVIA offers a mode it calls APRV/biphasic, represented by the waveforms on the right. In this mode, again, the ventilator delivers pressure-controlled IMV, but now spontaneous breaths during mandatory breaths are unrestricted. Notice that as the patient inspires during the mandatory breath, again, the airway pressure drops, but as the patient exhales, the pressure returns to the set inspiratory pressure, and the spontaneous tidal volume is vented through the expiratory limb of the circuit to the atmosphere. As a result, when the mandatory breath is time cycled, the exhaled volume is the same as it would have been if the spontaneous breath did not occur. Airway pressure release ventilation was first described over 20 years ago. The primary goals of this mode were to provide both safety and comfort. Safety in that adequate ventilatory support still had to be provided without depressing cardiac output, and comfort in that unrestricted spontaneous breathing would be allowed, which was unavailable in conventional modes of that period. To do this, the authors had to build their own ventilator. Whether they knew it or not, they essentially reproduced an infant ventilator that provided time-triggered, pressure-targeted, time-cycled breaths. But the authors conceived of APRV as being a system that provided two levels of CPAP rather than what it actually was and is, pressure-controlled intermittent mandatory ventilation. That conception of APRV has continued to the present and is even reflected in the way operator interfaces are designed on current ventilators that offer the ARP mode. This is both good news and bad news. On the one hand, APRV is distinguished from more primitive pressure control IMV control systems that do not allow unrestricted spontaneous breathing. But the bad news is that if clinicians do not understand that this mode delivers actual mandatory tidal volumes, they can easily overlook the fact that these volumes may not be delivered in a lung protective way. That is, they are sometimes too large. We'll go into this in more detail later. Unfortunately, authors seldom provide adequately explicit definitions for the terms they use when describing various modes of ventilation. As a result, for example, APRV has gotten confused with what has been called biphasic positive airway pressure, or BiPAP. This figure shows the characteristic waveforms of these two modes. The red curves are airway pressure, the blue is simulated muscle pressure, green is flow, and black is volume. Now, there are three things to notice in these waveforms. First, the general pattern of airway pressures is clearly intermittent mandatory ventilation, with relatively large pressure-targeted mandatory breaths occurring along with relatively small, unsupported spontaneous breaths. Second, APRV typically uses inverse IE ratios, or duty cycles greater than 50%, and BiPAP usually does not. Third, both modes allow unrestricted spontaneous breathing, both during and between mandatory breaths, but there is more time for them to occur during mandatory breaths with APRV. Finally, do not confuse BiPAP, as we are describing here, with the so-called BiPAP mode popularized by Respironics home care ventilators, for which pressure-targeted breaths are flow-cycled instead of time-cycled. At this point, we should review some conventions regarding the terminology of BiLevel ventilation. This figure shows the airway pressure waveform during APRV. Despite the fact that it looks just like pressure-controlled IMV, it is not labeled with familiar terms like peak inspiratory pressure, or PEEP, rate and IE ratio. There are indeed both mandatory and spontaneous breaths in APRV. However, because APRV has historically been viewed as alternating levels of CPAP, the amplitude of the time-triggered mandatory breaths has been called P high instead of inspiratory pressure, and the duration of these breaths is called T high instead of inspiratory time. In a similar fashion, expiratory pressure is called P low and expiratory time is called T low. Note that P high is measured relative to atmospheric pressure, as is common on infant ventilators and on some transport ventilators. This can cause confusion when switching a patient from a conventional pressure-controlled mode to APRV, because conventional pressure control modes for adults define inspiratory pressure relative to baseline pressure, or PEEP. The problem is that if you set P high and P low equal to PIP and PEEP on conventional pressure-controlled ventilation, you will end up with lower tidal volumes during APRV. If what I just explained is not obvious, you need to think about it until it is. To add to the confusion of how APRV is distinguished from BiPAP, manufacturers have used several different mode names along with differing user interfaces for their ventilators. To avoid further confusion in this presentation, we will henceforth use the term BiPAP to indicate pressure-controlled IMV with an IE ratio no more than 1:1. We will use the term APRV to indicate pressure-controlled IMV with an IE ratio greater than 1:1. APRV is primarily indicated for treatment of acute lung injury and acute respiratory distress syndrome. These conditions are difficult to treat because of the complex lung mechanics involved and the severe impairment of gas exchange. In this figure, we see a CT scan on the left. It shows the uneven nature of lung injury in patients with ARDS. Note that the superior regions of the lungs are aerated, while the inferior regions are collapsed. In terms of a pressure volume curve, we can visualize these lungs as having three zones. The open lung fields have the highest compliance, A, and hence tend to be over-distended. The middle region has somewhat less compliance, B, and may tend to be ventilated more on the steep portion of the PV curve. The consolidated areas may not open at all during inspiration, and the PV curve for this region, C, may represent just the compliance of the airways. Perhaps the most important feature of BiLevel modes is the potential for unrestricted spontaneous breathing. With these modes, unrestricted spontaneous breaths contribute from 10% to 40% of the total minute ventilation. This implies, of course, that the mandatory breaths contribute up to 90% of the minute ventilation. This is another reason why BiLevel should be recognized as a form of pressure-controlled intermittent mandatory ventilation. This figure shows the ideal placement of mandatory and spontaneous breaths on the pressure volume curve during BiLevel modes like APRV and BiPAP. If P high and P low were set at more extreme values, the effective compliance would be less and the work of spontaneous breathing would increase. The area below the ideal zone represents repeated lung collapse on expiration, leading to damage from shear forces, sometimes called atelectrauma. The area above the ideal zone represents repeated lung overdistension, leading to stretch damage, sometimes called volutrauma. Spontaneous, unassisted breathing is important because it results in a dramatically different ventilation pattern than when the patient is paralyzed and ventilated mechanically. These figures are from a classic paper by Froese and Bryan in 1974. They obtained radiographic evidence showing that for normal breathing, about 60% of the diaphragmatic movement occurs in the most dependent regions of the lungs for supine patients. In contrast, when the patient is paralyzed and attached to a ventilator, only about 10% of diaphragmatic motion occurs there. Thus, because perfusion is greatest in the dependent portions of the lung, normal breathing results in better ventilation-perfusion matching than mechanical ventilation. Therefore, we can postulate that allowing spontaneous, unassisted breaths during mandatory breaths may explain the decreased dead space ventilation observed in some APRV studies. Another major benefit of spontaneous breathing during any mode of ventilation is the resulting improved patient comfort. Improved comfort may lead to a reduced need for sedation. Studies have reported up to 70% reduction in the use of neuromuscular blocking agents and 40% reduction in sedation requirements compared to conventional ventilation. Furthermore, regular spontaneous breathing maintains diaphragmatic muscle condition and improves cardiac output. The patient can freely cough during mandatory breaths, contributing to secretion clearance and possibly reducing the risk of ventilator-associated pneumonia. All of these factors contribute to the potential for decreasing the duration of ventilation. The benefits of a prolonged inflation time, or T high, can be appreciated when we consider the uneven distribution of lung pathology in ARDS. Lung units with reduced compliance have short time constants, inflating and deflating rapidly. Lung units with normal compliance and perhaps increased resistance to secretions have relatively long time constants, inflating and deflating slowly. The use of longer inflation times promotes collateral ventilation among these units with different time constants through the canals of Lambert, the pores of Kahn, and the channels of Martin. Thus, the longer the inflation time, the greater the lung area potentially available for gas exchange. This mechanism may be responsible for the improved oxygenation observed in some APRV studies. Now, this figure summarizes the potential lung protective benefits of APRV over conventional volume control ventilation. For the same mean lung volume, APRV is shown operating at lower end inspiratory lung volume, avoiding the overdistension that volume control is shown causing in this example. Volume control requires higher tidal volumes to attain the same mean lung volume because it uses lower IDE ratios. Trying to increase the IDE ratio with volume control requires increased sedation to suppress the patient's desire to breathe against the ventilator. Of course, volume control could be operated with the same end inspiratory and end expiratory volumes, but it would result in lower mean lung volume and presumably lower oxygenation. Now, the practical problem is identifying the appropriate settings for APRV that will keep ventilation on the steep portion of the PV curve. The ideal approach to identifying appropriate BiLevel settings would be to first construct the patient's pressure volume curve. This figure illustrates PV curves using quasi-static inflation and deflation maneuvers on Hamilton's PV tool. With the PV curve on the left shows identification of the lower inflection point, the upper inflection point, the linear compliance between these points on the inflation limb, and the point of maximal curvature of the deflation limb. The presence of hysteresis, or the area between the inflation and the deflation limbs, indicates the potential for lung recruitment. Actual lung recruitment may be quantified by performing another quasi-static inflation with a 10-second inflation hold, which is the right PV curve, and measuring the increase in lung volume during this maneuver. The primary indication cited in the literature for the use of APRV or BiPAP is acute lung injury or atelectasis following surgery. However, one could argue that given the theoretical benefits of allowing unrestricted spontaneous breathing, the mode might be appropriate for a wider range of patients. On the other hand, remember that BiLevel modes are forms of IMV, and we can assume that the patient is able to support some portion of the total amendment ventilation with spontaneous breathing. Therefore, BiLevel modes might be contraindicated for patients who are heavily sedated or otherwise unable to support some portion of the spontaneous minute ventilation. And of course, inverse IDE ratios may be inappropriate for patients with severe obstructive lung disease. What are the goals of BiLevel modes? Well, from our previous discussion, we may conclude that the goals of BiLevel modes are to improve lung recruitment and hence oxygenation, to avoid the necessity to manage trigger and cycle synchrony and thus improve comfort, and perhaps reduce the need for sedation, and to provide a means for using a lung protective ventilation strategy by optimizing tidal and mean lung volume. The clinical evidence, however, for major outcomes of APRV are equivocal. One small study showed that mortality and ventilator-free days are not different between APRV and volume-controlled intermittent mandatory ventilation with pressure support. Yet another study showed that compared to pressure-controlled continuous mandatory ventilation, maintaining spontaneous breathing with APRV is associated with significantly fewer days of ventilator support, earlier extubation, and shorter stay in the ICU due to the lower level of sedation required for APRV. However, this study has been criticized because they paralyzed the patients on pressure-controlled CMV for 3 days, and thus any differences were probably due to differences in sedation use. One small randomized controlled trial of APRV as the primary mode of ventilation in ARDS showed no difference in clinically relevant outcomes. Now, I don't mean to suggest that these are the only studies out there. On the contrary, there are many, and there are more coming all the time because APRV and BiLevel modes are gaining popularity. But we still have no conclusive evidence that this mode is superior in terms of morbidity and mortality than any other mode, just as we have no evidence that any mode is better than any other mode, and we may never have that. Now, the current generation of ICU ventilators offer a number of adjuncts that can be applied during APRV. The mandatory breaths, that is T-high and P-high periods, can be synchronized with the patient's spontaneous breathing efforts. While this seems a reasonable way to improve comfort, only one study has been done using simulated breathing with inconclusive results. Compensation for endotracheal tube resistance using pressure assist in proportion to the inspiratory flow may reduce the work of spontaneous breathing in selected patients without deteriorating gas exchange. There are no data supporting the use of higher levels of assistance for spontaneous breaths during using pressure support. Based on our theoretical discussion, of the differences between unassisted breathing and full ventilatory support in terms of ventilation perfusion ratios, we might expect that the use of pressure support during APRV could be detrimental. If nothing else, it would potentially prolong the duration of ventilation, as it would complicate the process of deciding which variables to adjust and when for weaning. As alluded to earlier, there are essentially two schools of thought regarding the setting of T-low. And this is where things get complicated. I want to present some information that probably hasn't been addressed very well in the literature to date. Stocks and Downs originally described APRV as having a duty cycle of only about 45%, with a T-low of 1.3 seconds. Other authors, notably Hibashi et al., subsequently came to believe in more extreme duty cycles ranging from 80% to 95%, and focused on the setting of times for T-low instead of duty cycle or IDE ratio per se. The other school of thought, BiPAP, believes in setting more normal duty cycles and using a set PEEP to avoid lung collapse on expiration. The average reported T-low for BiPAP is about 3.4 seconds, which is about 5 time constants for patients with ARDS, and clearly enough time to avoid alveolar gas trapping and auto PEEP. The task of setting a short T-low with zero P-low deserves some discussion. This approach assumes that the clinician can select a short enough T-low to generate auto-PEEP equivalent to a level that would otherwise be directly set to avoid lung collapse during expiration. Hibashi has recommended that the T-low be set so that the expiratory flow is terminated at 50% to 75% of its peak value, which corresponds to approximately 1 time constant. This graphic shows that theoretically, the time constant for flow is the same as for exhaled volume. Thus, we might guess that if the expiratory time was terminated at, say, 50% of peak expiratory flow, then only half of the mandatory tidal volume would be exhaled, and hence auto-PEEP would be half the inspiratory pressure, assuming, of course, that P-low is 0. This implies that at the end of the T-low interval, the next mandatory breath starts when lung volume, and hence alveolar pressure, has decayed 50% to 75% of their values at end inspiration, because the time constants for flow, volume, and alveolar pressure are theoretically the same. For example, if T-low was set to terminate expiration at 50%, the peak expiratory flow and P-high was set to 20 centimeters of water, then auto-PEEP would be 10 centimeters of water. The practical problem with this approach is that peak expiratory flow varies from breath to breath, and an exact setting may be hard to discriminate on ventilator graphics displays. Furthermore, there is no way to determine alveolar pressure by visual inspection of the expiratory flow curve. At best, you can only estimate that peak alveolar pressure has dropped the same percentage as flow at any point in the expiratory curve. More importantly, some ventilators may not allow setting of very short expiratory times. For example, when the PB840 ventilator is used in BiLevel mode, it will not trigger a mandatory breath during the so-called restricted phase of exhalation. The restricted phase of exhalation is defined as the first 200 milliseconds of exhalation, or the period when expiratory flow is greater than 50% of peak expiratory flow, whichever is greater. Needless to say, the breath-by-breath auto-PEEP will vary, perhaps considerably, in contrast to a set PEEP value. This may not be detrimental, particularly in light of recent evidence favoring biologically variable ventilation, so long as it does not drop below the lower inflection point of the pressure-volume curve. Unfortunately, the most probable way of detecting this drop will be a loss of oxygenation. Draeger has created a feature they call auto-release in the new Evita Infinity 500 ventilator. Mandatory breaths are flow-triggered, but not on inspiratory flow as with conventional ventilation. They are triggered when expiratory flow decays to a preset percentage of the peak expiratory flow. The higher the threshold setting, the shorter the expiratory time, the smaller the mandatory tidal volume, and the higher the expected auto-PEEP. This feature makes it easy to set expiratory time in terms of the percent of peak expiratory flow, as we just discussed. This slide shows pressure and flow waveforms on a lung simulator using auto-release set at 50% of peak expiratory flow. The green waveform is pressure and the black is flow. We know that auto-PEEP is occurring because expiratory flow is interrupted by the start of each breath. The question is, how much auto-PEEP is there? When I showed this graphic to experienced clinicians, most of them pointed out that despite the fact that P-low was set to 0, airway pressure only fell to 2.5 centimeters of water before the next breath started. They suggested that this was the auto-PEEP. This, however, is not the correct answer. The green line is airway pressure, and auto-PEEP, by definition, is pressure in the lungs. Furthermore, we know that pressure in the lungs has to be higher than pressure at the airway at the beginning of inspiration because we have intentionally cut off expiratory flow with the auto-release trigger function. And for there to be flow from the lungs to the airway, the pressure in the lungs has to be higher than the pressure at the airway. But that still does not answer the question. How much is the auto-PEEP? The answer lies in the fact that when there's no flow from the lungs, there is no pressure difference between the lungs and the airway opening. Thus, pressure at the airway is an accurate reflection of lung pressure under static conditions, or when flow crosses 0. If we expand the time scale of the waveform, we can easily determine when expiratory flow crosses 0. The airway pressure at the moment is an estimate. The airway pressure at that moment is an estimate of auto-PEEP. In this case, we see that this pressure is about 9 centimeters of water. Note that when airway pressure reached its lowest value, that is 2.5, flow from the lungs was about 5 liters a minute. Thus, the end expiratory airway pressure, or PEEP, was due to the back pressure caused by the expiratory flow through the resistance of the expiratory portion of the patient circuit. Now, Habashi has also suggested that T-low can be set arbitrarily. His recommendations for adults with restrictive lung disease is as follows. P-high, 20 to 35 centimeters of water pressure, P-low equals 0, T-high, 4 to 6 seconds, and T-low, 0.2 to 0.8 seconds. In other words, you don't have to rely on the expiratory flow curve to set T-low. The implications of this strategy can be judged in this figure, based again on the theoretical response of a patient ventilator system. It illustrates the effect of the respiratory system time constant on the drop in alveolar pressure during T-low period of APRV. The curves represent extremes of time constant values based on published data for patients with ARDS. The figure also assumes that P-high is set at 25 centimeters of water and P-low is set at 0. Suppose an arbitrary T-low value of 0.8 was selected. If the patient had a long time constant, for example 0.7 seconds, an auto-PEEP of about 10 centimeters would result, the green line in the middle figure. This is about equivalent to the average value of set PEEP in the low tidal volume ARDS-NET study and is therefore probably appropriate. However, if the patient had a short time constant, say 0.24 seconds, the auto-PEEP would only be 6 centimeters or less, the blue line in the middle figure, clearly not sufficient to avoid either oxygenation problems or possibly atellect trauma. The other complicating factor is that not only does T-low affect auto-PEEP, but it also determines the mandatory tidal volume associated with the pressure releases. This is because the lung pressure and lung volume curves share the same time constant. Let us assume that the patient's compliance is typical of ARDS-NET patients that ranges from 30 to 70 milliliters per centimeter of water. Then the P-high setting of 25 centimeters of water shown in this slide would result in a tidal volume ranging from 709 milliliters to 1,106 milliliters. Of course, these volumes are too large for the average adult, and the P-high would have to be decreased. I have, however, seen actual patient data showing mandatory tidal volumes in this range because clinicians fail to recognize that the so-called pressure releases are actually mandatory tidal volumes. This is the potential danger of thinking of APRV as simply 2 levels of CPAP with tidal volume generated only by the patient's spontaneous efforts. Of equal importance, the examples of this in the previous slide illustrate the interdependence of P-high, T-low, auto-PEEP, and tidal volume. Furthermore, we can see how sensitive auto-PEEP and tidal volume are to changes in the time constant, as, for example, due to intermittent suctioning and resultant changes in airway resistance. The interdependence is even more complicated when you factor in the variability of both resistance and compliance to changes in airway pressure. To demonstrate the complexity of the interdependence of auto-PEEP, tidal volume, and T-low, this slide shows results of varying T-low for a typical patient with ARDS having a resistance of 10 centimeters of water per liter per second and compliance of 35 milliliters per centimeter water. P-high is set at 25 centimeters of water and P-low is 0. In general, as T-low increases, auto-PEEP decreases and tidal volume increases. However, for every P-high and T-low setting, there is a unique auto-PEEP tidal volume combination. In other words, you cannot adjust tidal volume independently of auto-PEEP. This graphic shows the results of testing auto-release in our laboratory using an Ingmar ASL 5000 lung simulator set to model a passive patient with ARDS. As percent peak expiratory flow was increased, expiratory time, in other words, the triggering mechanism of the auto-release, expiratory time decreased and end expiratory lung volume, that is, auto-PEEP, increased. The increase in auto-PEEP caused a decrease in the inspiratory pressure gradient between the airway opening and the lung, thus decreasing tidal volume. The change in expiratory time was a small fraction of the total cycle time, so the increase in mean airway pressure was minimal. PEEP at the airway opening increased above 0 as expiratory time decreased and ranged from 20 to 50% of auto-PEEP for peak expiratory flow percent greater than 0. This inadvertent PEEP was caused by the resistance of the expiratory limb of the ventilator circuit, not to be confused with the auto-PEEP. What we can conclude from this study is that appropriate use of the APRV mode requires careful consideration of the complex interactions of ventilator parameters. Using Habashi's suggested inspiratory trigger thresholds of 50 to 75% peak expiratory flow in this model resulted in tidal volume changes ranging from 345 to 510 milliliters and auto-PEEP from 15 to 20 centimeters of water. Expiratory times from 0.27 to 0.48 seconds resulted in tidal volumes ranging from 348 to 846 milliliters and auto-PEEP from 3 to 20 centimeters of water. These ranges are expected to vary with changes in patient resistance and compliance, further complicating ventilator management. Additionally, inadvertent PEEP at the airway greatly underestimates true auto-PEEP. Nevertheless, the percent peak expiratory flow trigger feature, in other words, auto-release on the Draeger ventilator, seems to provide more precise control during APRV than setting an arbitrary T-low. Things get even more complicated when you consider that different ventilators perform differently when delivering APRV. This is another study from our lab, again using a passive model of ARDS. P-high was 25 centimeters of water, P-low was 0 centimeters of water. T-low settings were varied from 1 to 6 time constants, in other words, from 0.3 seconds to 1.8 seconds. Ti was held constant. We found that none of the tested ventilators followed the mathematical model as expected and resulted in significantly different auto-PEEP, flow decay, and peak expiratory flow regardless of the T-low settings. Therefore, we conclude that setting T-low according to predicted time constants may not be reliable and results in higher than expected auto-PEEP. Now, this is something interesting. This slide and the next few show a graphic comparison of the short T-low zero PEEP method compared to the long T-low set PEEP approach. In other words, APRV versus BiPAP. This figure shows the APRV airway pressure waveform in blue. Mean airway pressure is indicated by the red line. The lung pressure or volume curve is shown in green. The expiratory time constant is such that the set T-low causes a reasonable level of auto-PEEP. The mandatory tidal volume is the change in lung volume during a mandatory breath. Next, we will see how BiPAP can achieve the same end expiratory alveolar pressure and tidal volume by simply increasing P-low and T-low and decreasing T-high. The APRV waveform is again shown in blue. Now this concept may be a bit confusing, so we'll go through it step by step. First, P-low is increased to the level of auto-PEEP during APRV. This action will increase mean airway pressure. The next step is to decrease T-high. T-high is decreased until the original mean airway pressure is achieved. Because we decrease T-high the same amount as we increase T-low, the ventilatory period remains the same, and hence the ventilatory frequency remains the same. Graphically, this means that the area that is increased under the P-low portion of the curve is offset by the reduction in area under the P-high portion of the curve. Finally, because the pressure change in the lungs remains the same, the tidal volume and hence minute ventilation remain the same. We have now turned APRV into BiPAP with the same tidal volume, mean airway pressure, and end expiratory lung volume. The advantage is that now we can directly control PEEP in the lungs, and more importantly, we can now adjust tidal volume independently of PEEP. The difference between APRV and BiPAP is largely a matter of whether auto PEEP is or is not better than set PEEP in terms of oxygenation and ventilation. Perhaps the best analysis available data has been written by Amato and Marini in Tobin's book, Principles and Practice of Mechanical Ventilation, 2nd edition. If we reduce the comparison of APRV and BiPAP to a discussion of the relative merits of auto PEEP or intrinsic PEEP versus set PEEP, then these authors conclude the following. Auto PEEP seems inferior to set PEEP in terms of oxygenation. There are not enough data to make any statements about ventilation. And in conclusion, there is no compelling argument for using auto PEEP instead of set PEEP. This slide shows the results of yet another study we performed in our lab. The previous slide showed that APRV and BiPAP could be set to obtain equivalent ventilatory parameters. However, this is seldom, if ever, done clinically. Instead, clinicians select arbitrary settings to generally allow auto PEEP or to prevent it. One way to do this logically is to base T-high and T-low settings on time constants. The purpose of this study was to compare major parameters of ventilation between the two modes when settings are based on time constants to manage expected end expiratory lung pressure and volume. This was a bench study using a lung simulator with spontaneous breathing in an ARDS model of respiratory disease. Both modes were set to a P-high of 25 centimeters of water. APRV had a T-low of 0.3 seconds, approximately equal to 1 time constant of respiratory system, with a theoretical auto PEEP level of 9 centimeters of water. BiPAP was set with a T-low of 1.5 seconds to minimize auto PEEP, while a set PEEP was 9 centimeters of water, equivalent to that estimated for APRV. The spontaneous tidal volume was the same for each mode. The results indicate that APRV resulted in a higher mean airway pressure but a lower tidal volume than BiPAP. Further research is needed to identify an optimum strategy for setting T-low and P-low. The clinical significance of our study needs to be validated in a human trial to compare the effects of oxygenation, ventilation, and hemodynamics between both modes. These are tips for managing APRV recommended by Hibachi. As we have seen in the previous slides, managing mean lung volume for oxygenation or mandatory tidal volume and frequency for ventilation may be easier said than done. If oxygenation is poor, check the end expiratory flow. If it is less than 50%, decrease T-low to increase end expiratory flow to 70%. This will increase auto PEEP and lessen the risk of derecruitment during exhalation from a mandatory breath. Increasing P-high will both increase mean airway pressure and tidal volume and potentially increase lung recruitment. If ventilation is poor, again check end expiratory flow. If it is greater than 50% and oxygenation is acceptable, then decrease T-low to get end expiratory flow to equal about 50%. This will increase the tidal volume exhaled from a mandatory breath. Tidal volume can also be increased by increasing P-high. Of course, minute ventilation can also be increased by increasing the frequency of mandatory breaths by decreasing T-high. Hibachi recommends that APRV be weaned by the so-called drop and stretch technique. This means to drop the P-high and simultaneously increase the T-high, which will decrease mean airway pressure. It will also decrease the mandatory minute ventilation by means of decreasing both tidal volume and frequency. When P-high is no more than 16 centimeters of water and T-high is between 12 and 15 seconds, then switch to CPAP at the same mean airway pressure with tube resistance compensation activated if available. Extubate when CPAP has been reduced to between 5 and 10 centimeters of water. Presumably, BiPAP could be weaned in the same way. In conclusion, I would like to leave you with 3 basic take-home messages. First, I hope this presentation has impressed upon you that mastering bi-level modes of ventilation is a more complicated task than it first appears. To do this, you must have a detailed knowledge of both lung mechanics and ventilator operation. Second, bi-level modes, such as APRV and BiPAP, are technically just pressure control IMV, but with unrestricted spontaneous breathing. The important thing to remember is that the so-called pressure releases are preceded by pressure rises, and the two comprise mandatory pressure control breaths that can be associated with large tidal volumes if care is not taken to assure appropriate settings. Finally, oxygenation and ventilation are affected in complex ways by the deceptively simple settings used in bi-level modes, and different ventilators perform differently with the same settings. Despite these issues, bi-level modes may offer some unique advantages and deserve consideration for acutely ill patients. I'm going to wrap it up there, and I thank you for your attention.
Well, Rob, I thank you very much for that extremely detailed presentation. And I think you certainly impressed folks with the need to understand these particular modes of ventilation to get the most out of them. You must have done such an excellent job. I have not seen one question yet come up in this entire webcast. But Rob, if people wanted to follow up this presentation with more detailed study, could you give us a couple of references, perhaps, where they might be able to find some better information or some more information?
Well, I can't off the top of my head, Bill, but I will tell you you look in PubMed, type in APRV, and you'll get dozens of papers. My suggestion would be to look for the review papers first. Great suggestion.
So going to the PubMed and typing in APRV and looking at the review papers would be a great way to get started in this then.
Also, if they can get their hands on Tobin's book on mechanical ventilation, particularly the second edition, Principles and Practice of Mechanical Ventilation, there are several unique chapters in there dealing with APRV or bi-level modes and pressure control in general.
And
very useful information there.
Spelled T-O-B-I-N, and his first name is Martin Tobin.
Martin.
Oh,
M-A-R-T.
Martin Tobin.
M-A-R-T-I-N.
That's correct. Okay. Well, Rob, seeing that there are no questions, we are getting close to the end of the hour, and I will. Whoa, here we go. I'm looking for questions here. And Rob, you can scan the box there too, if you don't mind. But I don't see anything that really we can address at this point. So.
I realize, Bill, that this was a very information-dense presentation, and so I would recommend to the listeners, if some of this is unfamiliar, to go back once you have it in the archives and look at it again. If anybody has any questions, please feel free to contact me. I'll discuss anything in this
very generous
slideshow.
Offer, Rob. I'm sure some of these folks will take you up on it. By the way, this will be up again on our webcast, in our archives, within the next week. And let's see here if we can go ahead and wrap this up here. For those of you that are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.